The world of peptides is a little bit sketchy territory for some. People don't understand where they fall in the realm of natural versus not. And there's practical applications for them, especially when it comes down to recovery. So I've got Dr. Kyle Gillett here, who is a repeat offender on this channel. So I want to talk sort of the basic peptides for recovery. But let's start with, what is a peptide in the first place?
Yeah, as you know, I like to talk about peptides, and I approach them similarly to any medication or supplement. And really, peptides are more in the medication category than the supplement category, but some people consider them in both. And all a peptide is a string of amino acids, which is a protein between 2 and a couple hundred amino acids.
Interesting. So how does that impact the human body just in general? If someone takes in a peptide and it's just a string of amino acids, doesn't that just ultimately end up in the pool of amino acids in our body? After today's video, I encourage you to try colostrum. You've probably heard people talking about it before. There's a company called ARMRA. Now, colostrum is not a supplement. It's more of a whole food. Okay, so in this particular case, ARMRA is 100% bovine colostrum that comes after the calves have been fed. So it's perfectly sustainable, but also comes from grass-fed cows, but also from a co-op of dairy farmers. So it's ensuring really high quality product. Now, what's interesting about this colostrum from ARMRA is that it is not heat pasteurized like most colostrum, making it the most bioavailable colostrum that you can find. What that means is that when you heat pasteurize it, it breaks everything down, the 400 different living nutrients that are in colostrum. So with their cold chain technology, it makes it so that it's ensuring the delivery of this stuff. The way that I've been using colostrum is to help with recovery. There's some literature that suggests that it's up to a 50% increase in recovery. Obviously very good for the gut. It can help rebuild that gut barrier, but overall just gives you a good sense of feeling energized and feeling recovered. So that link down below is going to get you 15% off. It's tryarmra.com/Thomas. Again, that's tryarmra.com/Thomas. So check them out.
Depending on how you take it and depending on what peptide it is. A good example of this is insulin. Insulin was one of the first peptides that was discovered, and I do consider it my favorite peptide because it is a life-saving peptide. And when we discovered insulin, it was less than a year until we were injecting it into diabetics in order to save their life. If you take a bottle of insulin and drink it, you are not going to absorb it, and you'll still die of diabetes. It was initially used mostly in type 1 diabetes, which is a different conversation that we can have, but initially type 1 was much more common than type 2 diabetes. But if you injected this insulin, then its bioavailability is better and it can save your life. Interesting.
Okay, so jumping around sort of the recovery aspect, I think one that people know a lot of or hear a lot about is one called BPC 157. This is one where, my own anecdotal experience with it. I mean, I texted you about this because I had never used BPC 157 before. I had it via IV when I was in Hawaii because I actually had kind of thrown out my back. I'm like, I'm just going to try it. What the heck? I'm getting some vitamins anyway. I don't know if it was placebo effect or what, but I mean, I felt significantly better and pretty quick. And I'm not opposed to the use of peptides, especially in this case of recovery. So what is BPC and what are some of these other ones that people can talk to their doctors about?
Yeah, BPC is essentially a bioidentical peptide, and it is a medication. There is clinical trials on it. There's not great ones. If people are more interested in the specifics of the clinical trials that have been done, they can check out my new podcast, Gillett Health Podcast, on our YouTube channel. But it is exactly what it sounds like. It is a compound that protects the body, a body protective compound. And the initial theory behind use is that there's a lot of research on PRP just for aesthetic reasons and also for musculoskeletal injury. Certain areas that have high amounts of collagen, like ligaments and tendons, are not well vascularized. For example, even in your meniscus, which is not a ligament or a tendon, there are some areas that are vascularized well and some areas that are not well vascularized. And VEGF, which is it's an angiogenic cytokine. VEGF is technically a cytokine, but VEGF is how BPC 157 works. In PRP, you have VEGF and a lot of growth factors. And you can replicate this with BPC 157 with the angiogenic potential of VEGF and also various growth factors like GHK-copper peptide or GHRPs or TB500, which is part of thymosin beta 4, which we can get into. But basically, it's replicating the way that your body heals itself naturally via plasma. When you injure, say, your knee or your back, it's normal for it to swell and have pain, because what happens is the capillaries are leaky and they're leaking out VEGF, among other things, and you're essentially delivering your own platelet-rich plasma. You're delivering your own plasma with those growth factors and peptides to the area, and this is a way that we replicate it exogenously.
Interesting. Okay, so, and VEGF is one of these things that is angiogenesis, for those of you that don't know, that's just the formation of new blood vessels. So especially in an area that may not get good blood flow to begin with, you're essentially kind of like kick-starting it a tiny bit.
Yeah, it's one of the, and it's not without risk as well. There's other medications that work on VEGF. Usually they block VEGF. Avastin is one of these, Avastin, and it's actually on the World Health Organization list of essential medications as chemotherapy med, because it's taken by people that have many different types of cancer. Cancer, as many people know, loves blood flow, and it expresses certain markers that are going to steal that blood flow away from other parts of the body using things like VEGF. So if you're able to block VEGF, then you can stop cancer progression. So the dose makes the poison with almost any medication, including BPC-157. It's one of the reasons why, as I've mentioned on my podcast, I've used it personally, but never continuously, only for acute injury, and usually not for periods of time more than about 6 weeks at a time.
Now, when you say 6 weeks at a time, I mean, is that every day? Is that, what kind of protocol are people looking at in sort of a safer way of this?
For an injury where your goal is angiogenesis to an area with poor blood flow, then often you can inject it. You can take it IV, even if you inject it in the area that's close. For example, if you injure your knee and you inject it subcutaneously near the knee, try to massage it in. A little bit of it does go disproportionately more in that area, which can be therapeutic. And you obviously want to minimize risk. So in cases of, let's say, a 40-year-old individual that has a knee injured, I would certainly more often prescribe injected subcutaneous BPC-157 and teach the patient or inject the patient myself in an area that is near that spot, rather than taking pills where theoretically you're going to have an even higher risk of growing a precancerous tumor, which are often already forming in the gut around age 40. But in another situation, if someone's gotten all their cancer screenings and cancer early detections out of the way, then perhaps we talk about the risk and the benefit and weigh that balance and be a bit more aggressive.
Now, I've seen some stuff, some literature on BPC-157 potentially increasing sort of growth hormone receptors in a given area. And I know that's still rodent model literature, but could that be part of the recovery aspect? And it could also be part of why some of the muscle building community likes to take this stuff a little bit more chronically.
Yeah, it's pretty likely. In fact, that's one of the reasons why BPC-157 is studied in Crohn's disease. So you have things like LDN, low-dose naltrexone that's studied in Crohn's. You also have growth hormone. HGH has actually been studied in Crohn's disease as well. But BPC-157 is also studied. If you think about it, it's an inflammatory condition, and they have trouble maintaining the brush border. They have a lot of inflammation in the gut. You would think that putting a cytokine like VEGF and increasing the activity of an inflammatory cytokine would make it worse, but it does not. So it likely does have other mechanisms of action as well.
Interesting. Now, I think the most popular study that people have probably seen or heard about is the Achilles tendon study. Now that one, although it's rodents, it's pretty interesting. I mean, can you give it kind of in a nutshell, just so people, I mean, that was one of the first studies that I saw on BPC, and I was like, wow, even though that's rodent model, that's pretty darn, like they would sever this Achilles tendon, and it was pretty interesting stuff.
Yeah, and again, obviously with the rodent model, that's a caveat that you can say, well, you still don't know if it can be applied to humans. However, there have been many humans that have also taken BPC-157, where you think about the Achilles tendon in a human, especially if it's a full thickness tear, that is just 100% a surgical intervention. There's some Achilles tears or partial tears that are not necessarily a surgical intervention, but even in case like that, the Achilles really isn't ever the same. It's usually looked at as a career-ending or a career-altering pathology. But there's a case, famously, I think Derek talked about it, there's a Russian gymnast, and I guess we don't know what that individual may have used or may have not used, but I believe it was only a couple months after an Achilles tendon tear that he was doing the vault in the Olympics as a gymnast. So there's definitely potential for cross-reactivity to humans.
Okay, so we've covered BPC 157 pretty well here. You mentioned a couple other ones that are potential recovery agents. Think, TB 500, which is another one that they put in that little cocktail of mine that I had in Hawaii. Which, again, I don't know if maybe that's why I felt so good too, but it just got me extra interested. Now, how does that work, and how does that potentially aid in recovery?
So TB 500 is a fragment of what used to be called Thymosin beta 4, which is another technically bioidentical peptide. You have the thymus, unless an individual has myasthenia gravis or other rare conditions, there's residual thymuses, but usually children have a thymus and then it shrinks to a point where you can no longer detect it when you're an adult. It's a small organ in the mediastinum, which is this area of the chest. And it makes a couple different peptides that are important for immunity and important for healing. Thymosin beta 4 is what they chopped up to make TB 500, and it does appear to work as a growth factor. So again, back to the PRP analogy, you have angiogenic potential and then you have growth factors other than growth hormone. And it can be seen as something that's arguably bioidentical that can be used in place of HGH. A lot of physicians prescribe HGH off-label for injury healing in certain situations and always when they think the benefit outweighs the risk. However, in my point of view, if you're looking at HGH, it's like a shotgun approach. You're using something that increases, that works on multiple different systems with multiple mechanisms of action, and it lacks the specificity to minimize harm potential. So you look at TB 500 as something that can take place of that for injury healing. You look at AOD 9604 or GHRPs as something that can take a place of growth hormone if you're looking for topical aesthetic benefit. And then you look at GHK-copper peptide, especially if someone is at an older age category or has a less healthy liver. That's another bioidentical that can help with very likely injury healing, but also has the potential to help with immunity as well.
Where does something like thymosin beta 4 or TB 500 come into play with general recovery? That's, again, and full disclaimer, I guess it's safe to say, Kyle's my doctor. So, can I say that? I don't.
Yeah.
Okay. So he's actually my doctor as well. And for the record, anyone that's interested in an amazing doctor, like Gillett Health has a plethora of amazing docs. But anyway, that being said, I inquired with you about this. I'm like, okay, what about I'm getting to an age now where I don't want to go on TRT. It's not really an option for me right now. I think I've got enough juice in the tank still. But the more I train, the more I run, I'm trying to do more than ever right now. And I want to aid recovery. Does something like TB 500, does it help recovery in that sense? I'm stiff a lot, right? The amount of running I do, the amount of lifting I do, or is that not really a use case for that?
That is a question that can't be answered with good medical evidence, but anecdotally, it can help recovery. The recovery would be a secondary benefit that you would derive from it. So in the case where you took HGH or pushed up your growth hormone or IGF-1, that would likely help recovery to some degree. But I don't think that you would say something like thymosin beta 4 or TB 500 would help recovery for sure, but there is a chance. So if there's something else that a different benefit that you're trying to achieve with it, for example, an injury to your back or an injury to your knee, then that's a nice secondary benefit. But in general, I don't recommend using it all the time continuously, because that's when the risks start to creep up. It's a cumulative risk.
Gotcha. So with TB 500, same sort of strategy as with BPC, like no more than 6 weeks, like a couple times a week, something like that?
Yeah, similar strategy. The one caveat with it is it's not quite as important if you're concerned with like the vascularization of the tissue or not, because that doesn't work on VEGF or angiogenesis. But very similar risk mitigation strategy.
So if someone is, I mean, this hypothetically, let's say they have a shoulder injury and it's not bad, but it's nagging them and it's an encumbrance to their training, that's the kind of application where maybe it might help expedite the recovery of that so they can still continue training in a moderate fashion. Is that appropriate to say?
Yes, and as I've talked about, I've personally used it for that myself as well.
Yeah, that's interesting. So that's one, and is that one that's still kind of the same idea, like site injection sort of deal? Or is it more just systemic?
It also works systemic, and both of those always do go systemic, but I recommend site injection. It's going to maximize your benefit while somewhat minimizing your risk.
Interesting. Okay, what else do we have in this category? TB500, BPC 157.
GHK-copper peptide is another one. So I also like to talk about the origin of these peptides. I talked about the thymus. BPC 157 a lot of times is correlated with the gut and gut health and also the stomach. So that's probably another reason why it's helpful for individuals with Crohn's, is that they have inflammation in the entire gut, all the way from the mouth all the way through the anus. Yeah,
let me interject there for just a second. So I mean, if someone has an inflamed gut and they've got, LPS, lipopolysaccharides leaking in, they could essentially be chronically inflamed. I know LDN works in a similar pathway. So maybe there's, people that are just feeling chronically inflamed. Is there an application for BPC 157 in that?
There could be, but at this time, it's hard to say, because when you're thinking about the gut, for example, Crohn's disease, that's probably the only scenario you can think of where you would consider oral BPC 157 capsules.
Okay.
And most other people, and also if you have Crohn's disease or gut inflammation, you're probably getting regular colonoscopy and EGD.
Interesting.
So if there's a precancerous tumor, then it's probably not there anymore.
Yeah.
So they have less risk and more benefit as well. In other cases of gut health, maybe, but it's not one of my go-tos.
Got it.
As far as prescribing BPC 157 capsules, I don't think I've done it yet, other than in cases of Crohn's disease.
Got it.
Anyway, back to the GHK-copper peptide. That's more related with liver health. I found an interesting product that claims to increase endogenous production of GHK-copper peptide. And you put a patch on, almost like you would put a NAD plus iontopore patch on. And I have no idea if it works, but they advertise it to individuals that are at very advanced age. And as you age, your liver loses its function. And we know as you age, your GHK-copper peptide levels decrease significantly. So that might have to do with immunity, might have to do with healing. We certainly know that children heal much faster than individuals who are in the 80 plus category. And GHK-copper peptide is likely one of those compounds that helps.
Interesting. Okay, so, and that's just specifically for the liver, in which case, it's just kind of like reprioritizing. If the liver's taking a hit, then other recovery aspects kind of take a back seat. Is that sort of what happens?
It's active systemically.
Got it.
In all tissues.
Interesting. Okay, so we've got GHK, we've got BPC, we've got TB500. Are those sort of the trifecta, or are there more in the recovery aspect? What are some ones that might possibly be safe for people to talk to their doctors about, more continual use that might help recovery? Or once you get into that world, the recovery world, is it really a dose makes the poison kind of thing?
Specifically for recovery, the next group that you'd probably talk about is GHRPs, which at this time are only indicated for very specific pathologies like lipodystrophy, which is an abnormally high amount of body fat in the visceral peritoneum, which is the abdomen, inside the abdomen. And then I think there's a GHRP that's indicated in rare types of leptin receptor deficiencies as well, but they're also indicated for various growth hormone deficiencies, or have been in the past. But those are usually not added in specifically for recovery. If you have a borderline growth hormone deficiency or a lower IGF-1, the Goldilocks zone for IGF-1 in general is between about 100 and about 250, but it depends on the individual, it depends on what your age is. If you're 15 years old and in your growth spurt, you probably don't want your IGF-1 to be 110 because you're not going to have enough growth velocity. If you're 80 years old and your IGF-1 is 110, and that might be great. An IGF-1 of 60 in that case might be acceptable. But if you're 25 or 30 years old, an IGF-1 of 60 would not only not be acceptable, it would also be clinically deficient, and your insurance company would even likely cover HGH. So I guess I say those examples just to explain the importance of individualized care when it comes to your growth hormone and IGF-1 axis. That's where GHRPs work, whether or not they're in the ghrelin agonist class or whether or not they're in the GHRH analog class.
Interesting. And I guess within that same vein, if someone's 80 years old and their IGF is 300, they have more potential mutations, more like abnormal growth that you could be accelerating. So I think that's something, although it sounds very simple and basic, it's like the older you get, the higher the risk of sort of this, going off in a way you don't want it to.
Yeah, one of the scariest cases that I ever saw was an individual who was, I wouldn't say in a geriatric age category, but certainly a bit older, 50s or 60s, and diagnosed actively with colon cancer. I believe status post-colectomy, so it had a part of the colon removed, had some of the surgery for the colon cancer, and was actually not on a GHRP that I knew of. So you wouldn't think that his IGF-1 would be particularly high, but was on BPC 157 and TB 500 and was on those medications for many months. And IGF-1 lab came back and it was around 400. Ooh. So it's hard to say. I do think that BPC 157 and possibly Thymosin beta 4 can increase IGF-1, but that just seemed way out of proportion. And anecdotally, I do notice that a lot of my patients with both benign and malignant tumors do have very high IGF-1s over 300. A low IGF-1 is correlated with a long life and longevity, but a mid-range IGF-1 is likely going to give you better functional outcomes and a better health span. That's why I call it the Goldilocks zone between about 100 and 250.
I mean, I guess while we're at this, are there things that people can do, even nutritionally or with their exercise or anything, to keep IGF within a healthy range, whether they're on peptides or not? Or is it something that's really just governed by, you hear all this stuff, right? Like it's, and kind of cutting through the noise on it.
Yeah. The answer to that won't be extremely exciting. People probably want to talk about, fasting mimicking diets or time restricted feeding or intermittent fasting or carbohydrate content or macronutrients. But at the end of the day, for the average American, the best way to modulate IGF-1 is to get your fasting insulin back into an acceptable range, which is, depending on the person, about 8 or below, or 6 or below if you're really concerned with risk of insulin resistance. So you want your HOMA-IR, that's your insulin resistance due to glucose and carbs, about 2 or below, and you want your LP-IR below about 50 or below. That's your insulin resistance due to lipids and triglyceride. So think of IGF-1. IGF-1 is mostly made in the liver, but there's also IGF-2. There's central IGF-1, which is made secondary to growth hormone secretion. Growth hormone comes from the pituitary, binds to the liver, and then increases IGF-1 and IGF-BP production. IGF-BPs are like SHBG. Think of them as taxis to take IGF-1 around to prevent it from being metabolized. And there are several of them. IGF-BP1 is what metformin is going to increase. IGF-BP3 is mostly genetic, but also secondary to growth hormone. Just like there's a whole bunch of sirtuins and SIRTs, there's a whole bunch of IGF-BPs. So it's a fairly complicated interplay, but at a 1,000-foot view, the rule of thumb is you think of insulin plus growth hormone equals IGF-1.
That's a very good way to put it. And I think most of the people that watch my channel probably have some methodologies at least to reduce insulin levels. And although it doesn't sound like an exciting answer, it's actually a very solid answer, because most people will just say caloric restriction. I think that's that's a much better answer than most people would think.
The other thing that I would say to that is I usually don't recommend trying to decrease your growth hormone level in order to decrease IGF-1.
Interesting. Just to two different systems altogether. Well, not two different systems, but I guess by trying to, I mean, growth hormone is broad. IGF's a little bit more specific, and then obviously it gets more specific from there.
Correct.
Gotcha.
Unless that individual happens to be on a high dose of a GHRP, like tesamorelin, ipamorelin, ibutamoren, which is now LUM-201. There's a whole bunch of these growth hormone releasing peptides, and it's not uncommon to have people come into clinic when they're on a dose that's usually meant for someone with lipodystrophy or someone with profound muscle wasting disease and visceral adiposity, and they just don't need it, and they have an IGF-1 of 500.
Interesting.
Usually when it's used off-label for borderline growth hormone deficiencies, it's only about 1/10 the dose. And again, it's individualized like everything else, but in general, it's a much lower dose than what is the on-label dosing.
Very good, very good. So, I mean, I guess at the end of the day, you know, don't be getting the stuff on the black market where you don't know what you're getting.
Yeah, it's just like any other medication, and peptides is a great buzzword, and I love talking about peptides because a lot of them have recent FDA indications. We could talk about Vyleesi, we could talk about Agrifta, tesamorelin's other name is Agrifta. We could talk about the melanocortin receptor agonists like setmelanotide and bremelanotide. Bremelanotide's Vyleesi, setmelanotide, I call it melanotan 4. It's indicated in Bardet-Biedl syndrome and melanocortin receptor deficiency, leptin receptor deficiency, all these rare genetic causes of obesity, which most people in the obesity medicine community are very familiar with it, but it can be used off-label as well. But at the end of the day, like I said, they're more similar to medications, and I recommend everyone talk to their own doctor about whether or not they might be right. And if I have a choice of something, and I'm biased because I'm a physician, then I would want something prescribed to me from a pharmacy by a doctor rather than something that's intended for research use.
Yeah, absolutely, man. Well, I mean, on that note, where can everyone find you?
My main hub is on Instagram, Kyle Gillett MD, and all other platforms, Gillett Health.
Perfect. Thanks, man.
Thank you.